Thank you very much for the excellent talks. I'd like to address the comparison between cross and flood again, Lizzie. You did not show the late toxicities or the toxicities of cross regarding lung. So I think irradiation induces also lung toxicities, and it is also a different population. I mean, we have to exclude really some patients with chronic obstructive lung disease for irradiation. And I think, do you have data on this? Is there any comparison or late toxicity with regard to cross? Also strictures in the esophagus?
Of course, there would be I'm not fully aware of the full incidence of those toxicities, and this is a consideration. I do think, however, you know, I'm not one of the cross investigators, but I think in actually Annals of Oncology last month, they presented a long-term quality of life follow-up for cross, and they showed very nicely that although there is a detriment to quality of life, as you might expect immediately after the treatment, that afterwards, that the quality of life was similar.
Yeah, okay.
I have a question.
It was GCO.
Okay.
It was GCO. Yes. Okay.
I have a question for Florian, actually. Hi. So outside of a clinical trial, what's your preferred approach for elderly fit patients in terms of perioperative or neoadjuvant strategy?
The cross or Folfox? Is it fine, this answer, even if it's short? Yeah, you do the same in Montreal. Yeah.
I have a question for you, Florian, with respect to regression in diffuse type cancer, because the Beck classification, or you also showed the Mandar classification, they are not, they have not been initiated with any diffuse type. And I mean, we have pathologists here, but I have a problem because you showed nicely the picture of Becker with fibrosis. You have to see the whole tumor bed. But how can you judge in a whole tumor bed in a diffuse type cancer how many cells have been dying during your treatment? And I mean, this reflects a bit the, you know, what you have seen between in your end results. I'm not sure if we have at the moment anything objectively to measure that.
I think you put, Paul, you put the finger into the wound, and it's an unresolved issue. Response evaluation in diffuse type gastric cancer seems difficult to me, and there is uncertainty about the data. I showed you our analysis pooled studies from Germany, which goes into the direction that we need to be careful to take histopathological response as a predictor to overall survival. Some data from the FLOT4 study may come out which may go into the same direction. We will see. At the current time point, I believe that measuring response in diffuse type gastric cancer is an unresolved issue. I would like to hear the comments from Heike or from Fatima on that, and that we should not take it as a good surrogate parameter for planning studies. Maybe it's good for the intestinal type, in my opinion problematic for the diffuse subtype. But maybe Heike or Fatima want to comment on that. It would be interesting to hear your opinion on that, if you want. Or Christoph Röcken is also still in the auditorium.
I mean, I can just agree with you that it's an unsolved issue. We can't see basically how many, as you said, how many cells were there before and how many have died now. Because it's just very difficult, if not impossible, to distinguish fibrosis from desmoplastic stroma. I think it's something we need to work on.
I have a question for Professor Terashima. Do you, when I see your picture and the strategies of GICC, and we compare it to ESMO guidelines and what we discuss here, do you think that we do overtreatment in a substantial part of patients with our neoadjuvant treatment?
Yeah, I think the staging system is very important. So even in the flood trial, many pathological stage 1 patient, it may be, we are not sure it's the down staging or naturally the early stage cancer. So I think if you include the clinical T2 or more patient, and I think more than 20% patient will be pathological stage 1. So of course, the imaging diagnosis is quite different between Japan and Europe, but I think that you can make more precise clinical imaging diagnosis and then use better enter only clinical stage 3 and stage 4 patient for neoadjuvant chemotherapy.
May I ask a second question? When you analyze your data in your adjuvant trials, did you subclassify into interstitial diffuse type? And do you see the same effect of your adjuvant treatment in diffuse type, or is there a difference?
Yeah. We try to make many subgroup analysis by histological type. We usually use the undifferentiated type and difference type. It's almost similar to Lorentz intestinal diffuse. So there is no difference, significant difference according to the histological type in any study.
Lizzie, can the discussion regarding chemo versus chemoradiation can be made irrespective of topographic localization, like severe classification?
I think that chemoradiation becomes more important as we move proximally. So just in view of the risk of an OR1 resection. So, but the surgical approach is also important. One of the conversations I had with Magnus Nielsen yesterday, actually, it's a pity he's not here, is we don't really have a lot of access to the surgical data from CROSS, so we don't know if chemoradiotherapy is helping for perhaps transhiatal resections. So I think there are a lot of factors to consider. Also, the expertise of the centre. So I think there's a learning curve for everything. Certainly not, we're learning to use FLOT at the moment. But for the more proximal the tumour, depending on the surgical approach, I think chemoradiation becomes progressively more important.
Florian, is there a reason to have different radiotherapy regimens in neoadjuvant or adjuvant? Or can we just have one that fits all?
I see at the current time point, I see very few value and justification for giving post-operative radiation therapy to anybody. I don't really see these patients. You can consider it, of course, after incomplete resection, R1 status, or incomplete nodal dissection, but we see very few of these patients. And probably this question should more be answered by Marcel Verhey, who is more an expert in this field. I just would like to add one comment to your question that you asked to Lizzie. In the German EOSOPAG study, which is comparing CROSS and FLOT, we are stratifying patients according to location of the tumor. We are stratifying CBOT 1 versus CBOT 2 and 3. So this may give some answer to your important comment. And
maybe I could add a few words on the radiation dose. For the esophageal case, we know that the 41.4 gray in the CROSS trial was a kind of in-between dose. It was a compromise, because in the period before CROSS, most patients were treated with 50 gray. And in retrospect, if you compare patients who received CROSS dose 41.4 versus 50 gray, there's essentially no difference in complications or toxicity. So in my view, the 41.4 gray is a rather modest radiation dose, and with the modern radiation techniques, a dose around 50 grays is perfectly safe to deliver. And I was wondering about the 32 gray dose in the Municon 2 trial, which is really a very low dose.
Yeah, it was a hypofractionated radiation therapy with 2 radiations per day. Yeah.
Right, so the
I
biological
should have
factors.
highlighted it on the slide, yeah. Yeah.
And in terms of gastric cancer, we give post-operative chemoradiation only if patients did not get pre-operative chemotherapy, and we consider post-operative chemoradiation when patients undergo an R1 resection in the MDT.
I have a question to Elizabeth Smith. You have shown in your talk the high number of not R0 resected patients with type 2. And you have discussed it with the chemotherapy. In my opinion, it's a question of the surgical technique. If you do an oesophagectomy with a hemigastrectomy, you have always a free proximal margin in these cases. If you do a transhiatal extended gastrectomy and you are not orientating to the situation before the radiochemotherapy, you have this high number of not R0 resections.
Thank you for that question. Actually, we've just finished a paper on the surgical outcomes in STO3, and I wonder if Bill Allen is here, if he could address that. He may not be here yet. But so, Bill is here. Great.
What's the question again? Thinking time.
There was a high number of not R0 resections in these trials.
Yep.
And it was discussed. It is possible to reduce it with FLOT or with cross, and in my opinion, it's a question of the surgical technique. If you do a transhiatal extended gastrectomy in type 2, the chance of a not R0 resection is much higher if you do a subtotal oesophagectomy with a proximal or a hemigastrectomy, because of, in these cases, in the proximal part, you have always a R0 resection.
Couldn't agree more. Absolutely, and it was one of the fascinating things to me over the last few years. When I first started coming and talking to colleagues in Germany particularly, they were talking about this extended total gastrectomy through opening the hiatus and doing anastomosis behind the heart. That's possibly, from the non-surgeons, the most difficult technique you can do. And in the UK, we've nearly always done esophago-gastrectomies. It's not only the proximal and distal margin, it's the circumferential margin. At ESMO Barcelona World Congress, I think it was 2 years ago, David Ilson threw down the challenge because he went through STO2, STO3, OEO5 and cross indeed, to say that in all the surgery alone arms you have a CRM of 30%. Cross cuts that down to 8%. If you do the operation properly, you can get it down into the teens, 10, 15%, by doing a wide resection of the crura at the hiatus. Specifically around the surgery in STO3, we have got similar features, but what the STO3, and I'll put it in my quality talk this afternoon, does show that by ensuring surgeons use the same technique, you can actually get better quality outcomes. So two surgeons would say the same thing on the basis if you do the operation properly, then you can get your contribution to the patient care. And what the non-surgical treatment is doing for us is actually putting us, I think, particularly with FLOT, into a new era where we can now begin to take on cases for surgery that we haven't been able to before because we've got additional modalities to treat those patients.
I would like to add something else to the first talk. Did you try to investigate cost effectiveness of the different approaches?
I don't think that there's been any health economic investigation of both approaches, but that's a very reasonable question, especially when you consider that there might be hospitalizations for febrile neutropenia, etc. And that's something I suppose that could be done for the investigators on both of those studies. Good point.
Okay. I also would like to discuss a very short point with Florian Loddig. You mentioned the situation of the non-responders. Would it be an option for you to do just best supportive care for those who are really non-responders in daily routine or maybe within new trials, just to investigate the possible additional benefit of any further active treatment compared to best supportive care?
I understand the consideration, and of course it depends also on the setting, squamous, adeno, and so on. But on the other hand, we shouldn't forget that even in the non-responders, for instance, it has been shown that salvage operation may lead to good long-term outcomes in a minority of patients, admittedly, but there still is something between 15 or 30% of patients who may become long-term survivors if they undergo more aggressive or more active treatment. So at the current time point, I would be cautious to recommend best supportive care alone. It may occur in frail patients or in special situations, but in the majority, I would say you have some reason to go forward and to do something.
Okay.
Hi, Rebecca Fitzgerald, Cambridge. Thank you for really beautiful, interesting talks. I want to come back to this rather difficult topic of whether we could spare some patients an operation altogether. Lizzie, you didn't comment on it, and we are seeing more complete pathological responses, which is really encouraging. Florian, I think you said the verdict was out. And I was also interested in the Japanese experience where they're giving patients chemotherapy for a year afterwards to improve outcomes. And I wonder if we need to be thinking about how we can then understand the biology of the tumour and perhaps be sparing some patients an operation if they have appear to have a complete pathological response, and giving them something else which might be a less toxic targeted therapy longer term to then see if we could spare them an operation and give them a better quality of life. How do we sort of bite the bullet and start to get some more evidence on whether for some patients they don't need an esophagectomy?
So is it for squamous or adeno, Rebecca?
Both, I guess. I mean, we see it more, of course, in squames.
Yeah, I think for squamous it would be.
Yeah, I couldn't agree more. And just a year ago, as EORTC, as a group, we had a nice application at Horizon 2020 where we proposed a non-operative approach for esophageal squamous cell carcinomas. Following the French and some other experiences on salvage surgery, we included early metabolic response assessment in this study because we believed that those patients who have an early response to induction chemotherapy may be the ones who have responsive tumors and may be good candidates for a non-operative approach added by salvage surgery if needed. So I think there are interesting, innovative designs we could think of, probably also involving biological features from molecular analysis. A lot of fantasy is needed there, a lot of patience is needed because the people who review these proposals also have other good proposals on their desk, and they don't always prioritize them, but I think there is a lot of reason to develop these organ-sparing approaches further, especially in squamous cell cancers where still the post-operative morbidity and mortality is quite considerable. Maybe not so important for the adenocarcinomas, but still they also would like to keep their stomach or their esophagus.
There's not so much data on adenocarcinoma. The largest data set is from Memorial at the time I was there, and they had a series of 700 patients and about 60 PCRs in adenocarcinoma. And what they showed was that the survival for the PCRs was the same as patients with stage 1 and stage 2. So we would operate on stage 1 and stage 2 for now. But you make a very good point about the addition of other therapies, because we know now that response to chemotherapy is intimately related with immune response. So perhaps these would be the patients in whom an adjuvant immune therapy, or a non-adjuvant, but to continue immune therapy might be helpful. So that's a very nice idea.
Thanks.
Just for information, the European chapter of IGCA, in collaboration with the Eureka project, is actually looking at how we can understand what's going on in more detail across Europe, particularly with the watch and wait principle around squames. I think we're going to really struggle to do that in adenocarcinoma because it's somewhat counterintuitive, and we've already seen the problems you've got with proving whether or not you've got a CR. But at the minute, there's a combined piece of work in development between UK, Holland, Italy, and Spain.
Hi, I'm Daniel Hannon from Leeds, UK. We've treated several patients with FLOT at our institution, and we've taken a controversial decision. We've only given the preoperative chemotherapy with 4 cycles of FLOT, and we've omitted the postoperative chemotherapy. For many of the perioperative trials, we know that many patients actually don't do well or get onto the postoperative chemotherapy. How do you feel about that? And I looked at the trial designs. A lot of the trials continue that rationale.
When you used ECX and MAGIC, did you give the postoperative
So we used to use
treatment?
OE05 previously,
okay.
yeah.
I understand why.
So
then.
that's why we use that approach. Okay. And I know it's controversial, but a lot of the trial designs continue to use postoperative chemotherapy. I was wondering whether we should try and move towards trials that just look at preoperative chemotherapy. I mean, the same in MAGIC. A lot of the patients didn't have postoperative chemotherapy. And that's the decision our institutions have taken.
Maybe I want to make a comment. Nobody knows the answer to what you are proposing. This is on evidence base. It's difficult to give a true answer. I was involved in, very much involved in an EORTC study that was published in 2010 with Schumacher as first author. And it is the only of the neoadjuvant studies that has been negative. And in this study, postoperative chemotherapy was omitted. The schedule was to give 12 weeks of platin-5FU-based neoadjuvant, followed by surgery versus surgery alone. There was only a trend towards better survival, and it was the only negative study formally. There may be different reasons. It was a smaller study, staging was very good, etc., etc. But to omit naturally a priori post-operative treatment seems a bit dangerous to me, because we don't have a true evidence for that. We all believe that it doesn't add too much to add this post-operative part, but when you go back to the data, the positive studies are the ones who gave the perioperative concept.
No, I agree. So I was wondering in the future trial designs whether you would consider omitting the postoperative chemotherapy.
Well, as a sequel to Critics 1, we're now running Critics 2 trial, where we indeed shift towards purely preoperative treatment and omit post-operative phase. Now, of course, that is in a phase 2 design, so if we identify the optimal schedule for preoperative, we, of course, want to compare that with the current standard. But I mean, we cannot ignore the fact that a large proportion of patients, 40 to 60%, just do not complete post-operative phase. So I think we should do a better job identifying those patients who cannot tolerate and only get toxicity of the post-operative phase. True. So I think it should be, of course, in trial setting, but there is rationale to put more emphasis on the preoperative phase of treatment.
I think, you know, with the expectation, you know, with postoperative therapy, we understand that half of patients won't be able to receive that. And I tell patients that from the outset. I say the expectation is that 1 in 2 patients will not be fit for it. And I'm comfortable with that. And so also we give a prolonged period after surgery, up to 12 weeks, to allow them to regain their fitness. But I think in patients who are fit and able, and perhaps who have benefited from preoperative treatment, that there is really an impetus to treat them if they're able for that.
Thank you.
Okay, well, I'd like to thank the speakers. I'd like to thank the audience for a very nice presentation.